This is our AGM to present the accounts and the report around performance. First of all, for the an element around the clinical commissioning group, because some of you will know that with the new Health and Care Act being introduced on the 1st of July, which brought integrated care boards into as a legal entity, that we still have in the first part of the year the accounts and performance to close down for CCG in its previous form on the 30th of June. So, can we move to the next slide, please? So, in terms of the transition from Dorset Clinical Commissioning to NHS Dorset, a little bit of background for everyone. As I said, the introduction of the Health and Care Act was on the 1st of July in 2022, and that led to the formal closure of clinical commissioning groups and the establishment of integrated care boards. Integrated care boards having a much broader remit and responsibility than clinical commissioning groups. The organisation moved from being a GP-led membership organisation to what we call a unitary board, which is very common in the NHS. It's what we consider to be a healthy board structure. And so what a unitary board does for members of the public who never worked with one before is it brings a level of collective responsibility for board members around the decision making, around strategic direction and the fulfilment of the statutory functions. So unlike in a private sector organisation where you may have the chief executive only at the board meeting and the trustees or non-execs holding that individual to account, in a unitary board we have all the executive around the table as well as the non-executive, because there is collective responsibility around decision making and direction. So a very different format. The Integrated Care Board is, its public name is NHS Dorset, and it's responsible for leading the integrated care system across Dorset on behalf of system partners, as well as being a system partner, which can be quite tricky at times. The system consists of our NHS organisations, which are Dorset County Hospital, Dorset Healthcare, and University Hospitals of Dorset in the east. We also have two higher tier local authorities, which are Bournemouth, Christchurch and Poole, and Dorset Council. We partner with our voluntary sector very strongly, and we have our primary care organisation, which is the GP Alliance, which our GPs and primary care organisations belong to. So it's and then we have business. So it's quite a broad sector of partners that come together in order to not just lead the development of health services for Dorset, but actually support communities to thrive in terms of their economic and social development. We also, during this year and possibly next year, will be taking on additional responsibility as an organisation in terms of commissioning of primary care services such as optometry, ophthalmics, pharmacy and dental, which were previously commissioned on our behalf and on the behalf of our communities by NHS England at the regional or national level. And then the next stage of that process in another 12 months' time will be that we will take on the commissioning of highly specialist services. Previously, we were commissioning local services, and then elements of specialist and other local services were commissioned elsewhere, and there's a possibility of divergence in terms of meeting the needs of the population. And now we'll be doing that all in one place, and the community will be a big part of the co-production of deciding how those services are delivered, where they're delivered, and what's important in terms of the outcomes that we're trying to achieve. So we are responsible for planning, buying and monitoring health services from healthcare providers such as hospitals, GP practices, for our local population, but we do that in partnership with them, and that's a very different approach than has been taken before. We also have a performance monitoring role as an ICB, and that means that it's our responsibility to make sure that the services that we commission, that the organisations we commission them from, are financially healthy and sustainable, that deliver the highest level of quality and safety that we would expect, and that they are well led and governed in terms of the way that they make decisions. Next slide, please. So in terms of the clinical commissioning group for the quarter one of last year, their key achievements were the smooth transition from the closure of the CCG into the establishment of NHS Dorset as an integrated care board. And I wouldn't underestimate the level of work involved in that in order to meet all the legal requirements of the new statute in the new legislation. Our continued response to the ongoing COVID-19 pandemic and the delivery of a robust vaccination programme was a really key achievement, and Dorset had one of the highest COVID vaccination rates in England, so I think we need to be really proud of that, and as a consequence the incidence of COVID was managed very well. Dorset practices performed above the national average in all key areas in the 2021 GP patient survey, and that has actually been replicated into 22 survey as well, so that was another really key achievement. In terms of the risks, the increase in costs in personal health commissioning has been a risk and continues to be a risk, as some of our communities' needs are more complex than before, and so we need to start to think about different packages of care to support them to remain independent for as long as possible. We all have a financial challenge, and we still have that, and that is replicated across the NHS with increasing demand for services as a result of an older population. The demand for acute mental health inpatient beds has increased, and that was on the increase, I think, probably before COVID, but COVID has exacerbated that with the impact in terms of our community's psychological and emotional well-being following the pandemic, and particularly the lockdown period. Workforce sustainability remains a challenge, and that is not unusual for rural areas where we need to think of different ways of recruiting people, and also different ways of making services more attractive for our communities to want to work in, and so that our young people choose to stay in Dorset post-education rather than leave. And then our capacity in general practice, because again, we've been very lucky in this area. We have a very high level of performance from general practice, but we are now starting to feel the pinch that other parts of the country are feeling in terms of the difficulty of recruiting new GPs and having the capacity to support initially trainee GPs so that they can keep them in Dorset. Slide, please, Louise. The performance of the clinical commissioning groups, the drive to continue to tackle the long waits, and we were able to eradicate our 2-year waiters last year in line with the government's targets that were set, and this year you'll see that we are actively working on trying to reduce waits to no longer than 78 weeks. The clinical commissioning group continue to lead work on the Dorset Health Villages in Dorchester and in Poole with the outpatient assessment centres, and that's been a great success in terms of reducing waits in some specialties and increasing the efficiency with which those services operate. And then we also saw an increased use of population health management approaches to address the overall health and wellbeing of the population, where we start to target different areas of our population based on the level of deprivation and the different approaches we might want to take to increase engagement in health services and reduce overall health. And the work we've done on COPD is a great example of that, where different types of engagement with our communities has reduced the number of emergency admissions throughout winter due to respiratory conditions. So we continue to progress that work going forward. Next slide, please. And then we move into the NHS Dorset and its establishment in July. And we work with a number of partners, as I said before, to deliver the 4 aims of integrated care systems which were set out in the legislation by government. And those aims, you can see, are improving outcomes, tackling inequality, enhancing productivity, and supporting social and economic development. And I think for us, the variation in outcomes that we achieve across health services is something that we need to tackle. And we're doing work on redeveloping our service umbrella so that we have Dorset-wide service specifications. So your experience of going to any of our providers should be no different, whilst the delivery mechanism might be different in the location that you're in, depending on the needs of the community, the transport infrastructure, and other factors that influence that. We need to be more productive. the NHS has lost a huge amount of productivity since COVID, and we need to start to move that up. That's one of the ways that we will start to reduce some of our waits for planned care. But I think the real prize of us coming together as a broader partnership beyond health is that we start to get more involved with the wider partnership in tackling inequalities across our communities, and doing that through the work that we all need to contribute to our own social and economic development. Next slide, please. So what were our achievements in the first 9 months? So we're really proud of the hard work and commitment of all of our teams, not just across the ICB, but across the system, in how we've come together as partners to develop a shared purpose, develop an integrated care strategy, and now think about what the priorities might be for the next 5 years. And particularly the work that we did on engaging our communities in that work, making sure that everything that was in our integrated care strategy was driven by the voices of our community through a whole range and series of interviews with them, which was trying to get underneath the detail of what it was like for them as individuals to live in Dorset and what they needed from us as a broader partnership to improve the quality of their lives, to improve their ability to achieve personal happiness, but also to move into a place of economic stability. So we met all of our statutory requirements when we set up the ICB, which was very positive. As I said, we developed the partnership strategy. We received excellent results in our first staff survey, which placed us as second in the country in out of all of the 42 ICBs. And we were shortlisted for a number of awards last year due to the work that we've done. Next slide, please, Louise. What are our risks going forward? We've got a huge financial challenge. Demand for services continues to outstrip the capacity that we have to manage them. So we need to find different ways of providing service. We need to be more productive. And that means not just changing the way that our teams work, but starting to use things like digital platforms more, so we start to be more productive and efficient. We also need to do a lot of transformation. There's a lot of duplication across the Dorset system, so we need to start to streamline services, connect them more, join them up more, so that our public have a better experience of using health and care across the system. They don't feel the join of services when they're referred from one element to the other, because very few of the people that use our services are only in touch with one part of the service. They're usually patients of their GP, they're in touch with secondary care, and they're also receiving support from local government. So joining those pathways up so that they flow more smoothly and give people a better experience and reduce duplication is really important. We're overspending on personal health commissioning, so we need to do some budget adjustment around that. We've got the oldest population in England, and so it's very unlikely that that spend is going to reduce. So we've got to think about ways of right-sizing that budget. Our ambulance response times, whilst they're good in Dorset, we are responsible for commissioning ambulance services for the whole of the South West region. Those response times are not good everywhere, and they're not consistently good. So we need to do more work on remodelling urgent and emergency care services and making sure that ambulances are not queuing up outside emergency departments and are instead responding in the right way at the right time frame for the conditions that our public are experiencing. We've got a high demand for acute mental health inpatient beds. Equally, we have delays in getting those individuals who are ready to be discharged out into the appropriate environment for their ongoing care. So we've got work to do there. And we have delays in hospital discharge, not just for inpatient mental health beds, but for inpatient beds across our acute and community sector. We've put a lot more resource, or our local government colleagues have this year, together with us, into the out-of-hospital provision, but we've still got more to do there to make sure that people are discharged in a timely way. Because we know for every day that an elderly, frail person stays in hospital longer than they need to when they are medically fit, that increases the chances of them going into long-term care because they start to decompensate in terms of muscle wastage. And there's also an increased chance that they're going to get a hospital-acquired infection. So we need to move on that, and we need to start to see some better progress on it. And then finally, we've got long waits for planned care both in acute and mental health. And while we are on target with meeting the national timeline, I think there's a conversation we need to have with each other about whether we're prepared to go further and faster in order to reduce those waits. Because again, we know that you wait longer for elective care, you are more likely to deteriorate while you're on the waiting list, and then the procedure that you need. Next slide, please, Louise. So our performance as an integrated care board, we've developed new discharge pathways with our partners, and they are having a significant impact on reducing the number of delays in hospital for discharges. So I think that's a real positive, and we need to keep going with that work. As I said, we delivered on the national challenge around reducing elective waits, but we've got further to go. And we were the second best performing system in the Southwest for a number of patients going to diagnostics, because we've made big improvements there. And our business case for a new diagnostic centres was approved, and we've now got 2 centres working in 2 of our most deprived communities in Wales and Boston. And that means that communities there can access diagnostics faster, which means for things like cancer, they're going to get new lead, which is fantastic. Next slide. So you can read more in our annual report, which is available online. But just so that you have a clearer view of our commitments, we are absolutely committed to improving quality and how we ensure continuous improvement in the quality of services that we commission. And we have agreed as a system our continuous improvement methodology, and we will continue to work on that in terms of improving services and the quality of them. But not just the quality, the access of services and how efficient they are for the use of the public. We have made a commitment that we will work with our people and communities and in a way that we've not done that before, really putting them at the centre of decision making, that we engage them fully in being a partner to the decisions that we take. And particularly when we start to think about what we do, what we call at place, which is in our 2 local authority boundaries. The aim eventually is that our communities will have the biggest say in how services are delivered and how public funding is spent in order to achieve better health and wellbeing. And we need to move to that place slowly by building positive relationships of equal partnership. We're committed to reducing health inequality and supporting the broader and social economic development. And that means being a good employer, making sure that we are employing as many people as we can from our local area, working with our educational institutions to make sure that our children are studying qualifications that enable them to enter into public service and see that as a long-term career. And that includes offering apprenticeships and different ways of getting people into service. We are a care leavers pilot site, a first implementer. That means giving care leavers the support to be able to enter into public service as long as we know that they will not only have career progression, but then it means procuring as much as we can locally so that we keep local people in jobs and supply chains, and that is important, an important piece of work. It means also working with local businesses and with our public sector partners to make sure we are offering decent wages that enable people to have a reasonable level of household wealth so they're not dependent on the public benefit system, and also that they can then achieve social mobility within their household. And it also means doing what we need to do on the green agenda, not just talking about it and not just having a strategy, but actually starting to make it real. 1, because it leads to healthier communities. 2, because we all have an obligation around social environment and the green agenda, but also because it creates employment. So we need to think about how we do that and work with a broad partnership in a way that makes sense to that. And ensuring that NHS Dorset is well led, has appropriate decision-making processes, manages risk in an appropriate way, and has the right internal controls in place to make sure that it spends its money wisely, that it can demonstrate value for money to the taxpayer that funds the services that we offer, and that we make decisions that ensure that we provide services of quality and that they're safe and they're accessible to the communities that need them. And you can clearly see there what we've got in terms of the year ahead. These are our 5-year forward plan objectives that we've all agreed with partners. and you can see that at least 2 of them focus on children and young people. That's because if we don't start to improve the way that we offer service to children and young people and improve their health and well-being, then we're going to see in the next 15 to 20 years a repeat of some of the poor health challenges that we've got. And then there's an opportunity to focus on deprivation. Some of our more deprived communities are struggling most, and also how do we support people as they move into older age to remain independent and still being able to contribute to society and feel valued and as if they belong. Next slide. And now I'll hand over to Rob Morgan, who's our Chief Finance Officer, who will take you through the annual accounts. Thank you.
Rob, I am also conscious of time because we need to start the public meeting at 1:45, so and I expect you to open for questions and things.
Right, thanks. Can you, if I face this way, can you hear me behind? Yeah. Okay, good. So I won't spend too long on. Thanks, Jenny, on this. If effectively, this is about the money. Clearly, it's the finance, some of the CCG and the ICB. Effectively, I'm going to just talk about 5 key duties that we have as a CCG and an ICB, and we are required to present that at our AGM as well. So the first 2 of them are about the amount of money we receive in the Department of Health. The following 2 are then a subset of that, about we get rules within there about how we spend the money on certain things. And then the final one's just about the cash, just the fact the way the money, we don't get given £1.6 billion at the start of the year and then drain our bank account. We draw down every month, so we have to forecast how much cash we need, then we draw it down, and at the end of the year we have to work with a certain tolerance of the amount of money left in the bank, which is quite a small amount. So the first duty is around what we call the RDEL. That's the Revenue Department Expenditure Limit. Revenue expenditure is effectively your day-to-day spending. So it would be like what we spend at the supermarket. It's about pay, it's about paying for the services. It's that day-to-day running of our businesses. That's different to the second performance, the second duty, which is around the CDEL, which is the Capital Department Expenditure Limit. And that's more about those assets that you have, so the estate, the IT systems that will last for a long time. So on the first one, we get a certain amount of money given to us to run our services, and of course, we have to stick within that limit. So if you just move on to the next slide. At planning, because we are told how much we get given before the year starts, we were told that between the CCG and the ICB, we could expect to get just under £1.6 billion for Dorset, and that's a huge number. It feels a massive number, doesn't it? And if you can do the maths there, that the CCG was in existence for 3/12 of a year, so a quarter. So there's no surprise that a quarter of the money was CCG and 3/4 of the money was for the ICB. So we set plans to spend £1.6 billion. We publish our plans. The reality of it is that as we move through the year, we often get given a bit more money. So we get given what's called non-recurrent money. And they are sort of pump priming pieces of money or money for special reasons. So usually we end up getting money ahead of winter. It used to be called winter planning. I think it's called demand and capacity money now. So actually we received £100 million more than the 1.59 billion. So we got just under £1.7 billion. Just because we receive £100 million doesn't mean we stick it in our pocket and it's a surplus. We have to spend it. Clearly, we have to spend on the services that it's intended for. So pleased to say that for both the CCG and the ICB, we met the RDEL requirement, so the revenue resource requirement, that we spent what we had and we didn't overspend, I think is really the message on that one. If you just move on to the next one. The next one's around the capital. Now, when we get onto the next slide for the numbers, and sometimes I have to check myself because I'm going to say it's quite a small number and yet it's still millions, but we are talking in very big numbers with billions. The ICB, and that's what we're talking about, our ICB accounts, we're not paying for all the capital around our providers, so for hospitals and things like that. Okay, we're responsible for primary care estate, responsible for the IT equipment, so it's quite a small number compared to what you would see in provider accounts, how much they spend on capital. So again, it's the same thing. We get given a limit of what we can spend, and we have to spend within that. Just as an aside, we also now, as part of being in a system control total environment, we have to also make sure that as a system, our providers live within their capital limits as well. And we have to make sure that as a whole Dorset system, we do also live within that means. And that's the same with the revenue as well. So if you just move on. So this is about as complicated as any of my slides are going to get. There's two boxes there. The first one is that NHS England actually hold money and they account for it, so it's in their books. So in the top, there's £1.4 million that is spent in Dorset, but it's not in the ICB's books. Okay, that's in the NHS England's books. And that's to do with minor improvement grants for general practice estate. That's not a lot of money, as you can see, just £287,000. And then you've got the GP, IM&Ts, the IT equipment for GP practice as well, which is more, it's 1.1 million. But again, it's not a whole load of money in the big scheme of things. And then the bit that actually comes to us at the bottom is just under £1 million. And that's really for what we're looking at here, you know, paying for the building, paying for the IT equipment that we as an ICB use. So again, it's a fairly small number. And again, we live within that number. So we achieve that duty. You can move on. The next one, within that first duty, the revenue resource limit, what we spend on day to day, which covers pay, we get a limit on how much we're allowed to spend on running the ICB. So we call it a running cost limit, but it's effectively the administrative costs of running this organisation. It's £17 million. It's a national formula that looks at the population that Dorset has, and you get £1 per head of population. So we all get the same amount per head of population, no matter what ICB you're in the country. If you're a larger ICB, you get money therefore, and if you're a smaller ICB, you get less money. We're around we're one of the smaller ICBs, but we do get £17 million a year to pay on the administrative costs of running the organisation. So if you'd like to click on. The fourth duty, something slightly wrong on the heading. Again, another piece of information that we're told we have to do is the mental health investment standard. So within that first duty, with all the money we get, that £1.7 billion, there's something called the mental health investment standard. And what that says is that you have to invest in mental health at an amount that is proportionately higher than your overall growth. So you proportionately invest more in mental health. This is a national standard. It was introduced quite a few years ago, and it's called the parity of esteem at the time, and it's moved into the mental health investment standard. It's something that is absolutely looked at really, really hard across the country, because for years mental health didn't get the investment it was required, and this standard has shifted money towards mental health. Always questions about, is it enough still? Of course. And again, what we see there is that we spent just under £120 million, which was over £5 million increase in the previous year. The mental health investment standard said that we should spend 119 million, 190.1. We were just under 120, so we overachieved. So we shifted more money towards mental health than the standard required us to, which is a good thing, again. So if you just move on. This slide is just a bit of a breakdown of how that 1.7 billion pie is split up. It's probably easier just the graphic on the bottom right. So you'll see that for every pound we spend, over half of it just goes on secondary care, and that's your hospital services, your acute hospitals and things. Primary care also gets a fair amount of money. Then you're getting into mental health. Tricia had mentioned the personal health commissioning, and then the community services. So you'll see that pretty much takes up most of the money, those big chunks. It's always interesting sometimes to ask people about, is that what you'd expect to see, actually? Because, usually our first contact with health services is in the community, and then you see how the money is spent. There's also things in there like the Better Care Fund. That's where we put money into joint pots with our local authority partners as well, to encourage more joint work with our local authorities. And that's something, again, that as we move into the future, we'll be looking at working more together on. And then again, obviously you've got the admin costs as well, and a little bit of other stuff. If you'd like to move on. So the final one is just an interesting one. It probably doesn't mean much to anyone, but I'm always quite proud of the finance teams on this one. When you run this through, and remember that not everything's cash, there's accruals and things like that, but there's over 1.3 billion pounds worth of cash transactions that went through, and we ended up within £41,000. Now, again, that is a set limit as a percentage of your overall spend that you have to finish the year in. So what the NHS doesn't want is they don't want integrated care boards saying we need 10 million next month and actually they only spend 8 million, because that leaves 2 million unspent and causes a problem. They want you to be accurate on your forecasting. So I guess the point on this slide really is, of course, we achieved the standards, but what it shows is that we're pretty good at working through that drawdown. We live within the limits, and every month we always do. So we never get to a point where we can't pay the services. We haven't pulled down enough money. We get it pretty much right month on month on month. And that's it for the 5 duties of the ICB. There's one more slide. Patricia's probably touched on some of them around the risks. But that's again, he's talking about 23, 24. That's now. We're not far off halfway through the year, probably not quite halfway through the year. So we already had these in our plan as well about recovering the core services and productivity. We know there's a big productivity challenge in the NHS now. After COVID, there's a lot more people working in the NHS. We know the waiting lists are high and we know the activity's down. So we know that's one of our challenges. We've got to improve ambulance response and A&E waiting times. We've got the NHS long-term plan ambitions. That's looking at trying to see how we can make things more sustainable. We've got this big challenge financially, but we've got workforce challenges. We've got challenges all over the place, as have our partners as well. And that's why we need to work together, which comes into the final point, which is around transforming the NHS. And that's really working with our partners. We've got the Integrated Care Partnership. We've got the Integrated Care Partnership strategy. We've got the joint 5-year forward plan. There's lots of jointness in this. There's lots of working together. That's where we need to be moving to transform things so that we can continue to present rather dull slides saying we managed to hit the financial numbers. Behind that, there's a whole load of good stuff that goes on.
Thank you very much. So firstly, I want to say thank you to Patricia and Rob for bringing the last year of work that we've done and set out in the annual report and accounts, and also for setting that out quite clearly. So thank you for that. We did actually go out to the public for questions, and we haven't received any. So I'm going to, in the next 5 minutes, just open for any questions or comments around the table. So is there anybody? Matthew?
Thank you, Jenny. Thanks, Patricia and Rob. Thanks, Rob, for presenting the numbers so clearly. As colleagues know, my role on this board really is representing mental health as a partner. So I want to just say something about the mental health investment standard, which you presented really clearly and well, Rob. And I would just advocate that that's a minimum standard. So when we have a discussion about overachievement, that's the right place to be and the place that we would want to be in terms of seeing and delivering the strategic change that's in line with our population health ambitions.
Anybody else? I know the board has seen the accounts and the annual report before when it was all pulled together, which is on the website. But are there any more questions or comments? Okay.
I just wanted to say that reading the papers that went with this, I was struck by the breadth of ambition that we are showing there in looking forward. And I think that's something that should be welcomed by everybody around the board, because we do want this to be different from the old system. And I think the report does show that even in the early stages, we are setting out our stall in such a way as to make it clear where we want to be and where we want to go and what those ambitions are. I think that's really important, that right from the get-go, we have those set out there so clearly.
Just building on that, because it's a really important point, and it's kind of a question and a statement, is getting that balance right between tackling the priorities today as we see them, but then building good foundations to get to the root cause of these problems is a really difficult balance to get, because it can look like we're not putting enough money into the problems of today, when actually we're putting money into stopping those problems recurring and recurring. And it's just a question really to both Rob in terms of financial and Patricia generally. Do you think that that balance is set right at the moment? Do you see that balance changing? And do you have any comments on that?
I'll let you go.
So the balance between the doing and
the now and the future.
Yeah. So we've been having this debate recently.
That's fine.
I think we were having this conversation actually yesterday, and you know you've got a number of priorities that compete with each other. We've got to make sure the services we provide are safe. We've got to make sure our staff are looked after and cared for, so they'll do a good job. We've got to deliver on the money, and we've got to make sure that people can access services where they need to. And then we've got the balance of the here and now and the future. And I get asked all the time, well, which is it? Is it going to be all the quality? Which are we going for? Is it here and now, or is it the future? And the reality is, the answer is all of them. You know, because we cannot deliver on quality unless we're spending our money wisely. We can't deliver good access unless we're also thinking about quality and safety, because access is part of the quality and safety question. So it's all of it. And we were having a conversation this week about the fact that we need, as an executive team, as much as we can stay on the balcony of the strategy and where we're heading. And yes, let our teams get on with some of them with the here and now and make sure that they deliver on the operational day to day, and us only going down into the weeds of that when we absolutely need to support them and being there for as short a time as possible and get back up on the balcony. Because otherwise we lose the thread of where we're heading. And the reality for us is, if we don't concentrate on today and the next 5 to 10 years and set the foundations for the transformation programme that we need to deliver this year, we're not going to be ready when we need to be to step off that platform and do that transformation. That means that we improve the overall health and well-being of our population, that they live longer and healthier, and we're part of that journey with them. So it's both. And I think we're just getting round to understanding what proportion of each we really need to focus on to make sure we manage to move both agendas forward in parallel.
Thank you, that's really helpful. Rob, did you want to add anything?
It is a conundrum, isn't it? So those statutory duties, no matter how much we'd like them to be important, to get there, they're annual, and there's always that tension between all running to one side of the pitch and forgetting about the other end, isn't there? And I know that's just kind of like stating the obvious, but that's that conundrum. The final slide I put up was talking about transformation. We have to do the transformation in order to be sustainable in the future. But it's really difficult to do the transformation if we're overwhelmed and in the here and now moment. And then I do always think, yeah, I'm in my ivory castle in finance, aren't I, looking down? I'm not on the front line. And the front line are really, really pressured and really, really tired. So it's a really difficult ask, but we know that's the challenge. And it is that balance that somehow we've got to try and figure out how we don't just all run to one side of the pitch, because we'll let go of something, and it's just trying to keep that net and trying to catch everything. So yeah, no real answer there apart from we're more than aware of it, and we that's what we're all trying to grapple with as a board and in our partner organisations as well.
Patricia did say also you're doing the thinking through now about where you put the money. So
and I think part of the conversation has been, yes, there are all these national priorities, but actually, are they what's important to the community? Because if they're not, then we need to deliver the ones that are, and we need to have a dialogue about the others, because actually there's no point in delivering 35 priorities if only 20 of them are important to our community. Because that's at the end of the day what we're here to do.
Okay, I've got Dan and John, and we've got 1 minute left, so you're both going to have to be really quick.
At the risk of stealing your thunder, Jenny, I just wanted to say thank you to all the exec teams across the system. A lot of work goes into landing. There's more work to do, as we've heard, but to land that position, performance and finance, I just think it's really important that we acknowledge the exec team's leadership, but then across the teams they lead, the work that they put in over the course of the year. So I suspect you were going to say that as well, but I'll say it first and then you say it again.
John.
It was a very similar point. What really came across to me is that there's been a lot of change in this first year, the CCG moving into the ICB context. But to hear about the engagement within the teams, but actually that team coming together in service of the people of Dorset, to be able to have a first period, but then, Rob, you outlined some of the things for the future and that transformation to deliver outcomes here in Dorset. I really heard that, and I wanted to acknowledge that the whole team who have done that, integrated team.
Great. So I was just going to close by saying that the report demonstrates, and Patricia emphasised, that actually we've been able to achieve the successes we have and manage the risks that we've been managing because of the integrated collective work. And Patricia talked many times about the various different partners. And we will only continue to serve our communities well if we make sure that that stays as the kind of bedrock through the things that we're doing. So thank you, of course, to the ICB team and all the work that you've put in, because it was a huge ask to set up a brand new organisation, close down the old one, but still achieve some really good things. But also thank you to the wider partners who've walked this journey with us and been part of that. Been part of that journey, really. That's